respected chairperson, colleagues. Today the topic is heart failure, and my today the topic is hello. Today the topic is heart failure, and my intention is to tell you what the new development has happened in last 2-3 years. Everything started in 2009 when a new molecule was tried, and we are going to discuss about the impact of that new molecule in treatment of heart failure. But why we have taken the heart failure as our main topic and not keeping away from coronary artery disease, keeping away from interventions? That is the question which audience may be interested with. And I would like to tell you that heart failure is nowadays going rampant. What is happening is that 1 out of every 3rd heart failure patients will be dying in 1 year of time. So any patient coming to you with breathlessness, you are referred to a physician for heart failure, and suddenly you know that probably patient is no more. And that happens 1 in a third time. 1 in a third time patient will have readmission. After 1 month again he gets readmitted to heart failure hospital. Why? Because either there is some respiratory tract infection, or there is some propagation of heart failure, or he has sustained some waterlogging inside in his lungs and gets admitted. So the cost to the family goes tremendously high, not only the death, readmission also. And India, if you have one readmission, then probably the mortality is 3 times higher. So that's the scenario. Every 3rd patient going for sad demise in next 1 year. Very important thing. What is the burden of the disease? Burden of the disease is 62 million patients, gradually increasing even in India. What is happening is that our life expectancy at birth is increasing. We have more aging population. We have increasing prevalence of risk factors. Dr. Khaitan has already narrated diabetes, obesity, hypertension. And so risk factors are increasing, aging population, and we have improved post-MI survival. Almost all cardiologists are happy to do PTCA, improving the survival after myocardial infarction. So post-myocardial infarction, they will have to have some residual damage, and that residual damage will lead to heart failure. So global scenario is that at 70 years of age, most patients present with heart failure. And what is our scenario? 53 years of age. We have in-hospital mortality almost 10 times higher than Western world. We have post-infarction post-discharge mortality at 6 months is very high. And what is that? That is because of recurrent admissions. The first admission comes in 24% of patients, and the second admission comes in 5% of the patients. Mortality is very high. 1/3 of the patients die within 1 year, and many of them are at greatest risk at 1 year, less than 70 years of age. This is about advanced heart failure. But let me tell you something about mild to moderate symptoms of heart failure. If you have a mild to moderate symptoms of heart failure and you prescribe some medicine in your clinic, but then also there are 29% chance that that patient will die of cardiovascular death, and this is the data of 2003. What has changed? In 2011, the same kind of data, 22% of patients are still having probability of dying, and that too in 1 year of therapy. Heart failure therapy has evolved very significantly from last 25 years or 20 years. And look at the things, beta blocker came, ACE inhibitor came, cardiac devices came, and still we are at a crossroad where we don't improve the survival in heart failure. So why this grim picture? This grim picture is to tell you that we needed a very mammoth effort. ACE inhibitors came and 16% reduction in mortality. Beta blockers came, 34% reduction in mortality. Beta blockers were previously not advocated in heart failure, but Then beta blockers in heart failure came and 34% reduction in heart failure. You have aldactone type of molecule, mineralocorticoid receptor antagonist, and you have 30% reduction in heart failure death. So this is the scenario which went on over a period of time, but still 50% of patients are still having rapid downhill course. And so we need to go ahead, and that is why our attention came to neprilysin. I would just draw your attention, what is neprilysin? Everybody has listened to numerous lectures of angiotensin 2, angiotensin 1, angiotensin 1, ACE inhibitor, ARB, angiotensin receptor antagonist. But still, there will be one more molecule which will be neprilysin inhibitor. What is neprilysin? Neprilysin is a degradation of vasodilatory substances. So we have the first neprilysin inhibitor, and that will be combined with vasodilator angiotensin receptor antagonist. Look at this. This is very important point where I would like to draw your attention that neprilysin, what neprilysin does, different kind of natriuretic peptide will be degraded to inactive fragments, and these peptides are very beneficial. Vasodilatation, decreasing blood pressure, decreasing sympathetic tone. So up till now our more attention was in ACE inhibitor and ARB scenario, and this was the mainstay of our therapy. But now the therapy changes, we go on continuing with this kind of thing, ACE inhibitor, ARB, but add a neprilysin inhibitor. What will happen? Neprilysin inhibitor will stop degradation of a vasoactive compound, and vasoactive compound will also increase in substance. So here, what up till now we have been doing was stopping the downgradation of vasoconstrictor substances, but now we are lifting up the vasodilator substances also, and that is a paradigm shift. By paradigm shift, I mean to say that suddenly our goal has changed. Our goal was to reduce angiotensin 2, but now our goal has been to improve or increase the vasoactive substances also. And the trial which came was in 2015, and that resulted in significant reduction in mortality, cumulative probability of dying, cardiovascular death, or first heart failure, hospitalization. You know, the total patients were more than 8,000 patients, and 20% reduction. The graph started changing less than 180 days, and this is the trial which concluded in 2015, has at almost 4 years of follow-up. So with 4 years of follow-up, and you have death reduction by 20%, and the graph started separating at 6 months time. You have first hospitalization also changing, 21% reduction in first hospitalization, and the patients were followed up for 4 years or more than that. So the scenario is that you have a wonder molecule, and this is wonder molecule combination of ARB, namely valsartan, and addition of neprilysin inhibitor, what is called as ARNI. And this should be started with 50 mg twice a day. 50 mg, sometimes people believe that Indian scenario we have to reduce the dose. There are consultants who start with the ARNI dosage of 50 mg, half tablet twice a day, and they go on increasing over every third or fourth week of time. And you can see that it was compared with enalapril, head-to-head comparison. Up till now in heart failure, enalapril was the gold standard. So we compared with enalapril and the new molecule, and you can see that all p-values are so significant. That means hypotension is not very much deleterious. You don't have very significant elevated serum creatinine levels also. So the molecule is very safe. And then the new introduction was that sacubitril valsartan started from European Society guideline in 2016. It was class 1 indication. So any heart failure patients, whether mild or moderate or severe heart failure, you should start. Then Americans immediately followed the European recommendation in 2016 itself, the class 1 indication and guidelines. So 2017 also the guidelines followed the same suit, and we have a class 1 indication of sacubitril valsartan combination gradually going up by every third or fourth week, and maximum tolerated dose was 200 milligram twice a day. It was up till now the largest mortality benefit trial in heart failure reduced ejection fraction. We have patients with NYHA class 2, milder patients, and you can see that 20% reduction in sudden cardiac death. I'm just repeating these slides. So the dosage gradually was increased, but there is a very important aspect here, that if your patient is on enalapril, if your patient is already on ramipril, then stop that ramipril for 36 hours. Why? Because ACE inhibitors, if they are continued, there is a high chance of angioedema with the new molecule. So first of all, ACE inhibitor has to be stopped for 36 hours, and then you go ahead with a new molecule called as sacubitril valsartan. But here again, if your patient is already on telmisartan, valsartan, or any sartan, say losartan, then probably you don't have to wait. You can switch directly to the new molecule sacubitril valsartan combination. Paradigm heart failure was the trial's name, published in 2015. Up till now, not coming to a very significant impact to the general practice physicians. But let me tell you that if your patient is 55 years old patient, heart failure patients, and if he starts receiving this new molecule sacubitril valsartan, then there are chances that your patient will live 1.4 years longer. Very significant. If I say to my patient that you are likely to live 1.5 years longer, that is very significant. Dot વર્ષ વધી જાય છે જિંદગીનું. So we have a very impact of 2.1 years of event-free survival also. So recurrent admissions are not there, and survival benefits are very important even in different class of patients. If your patient is more than 65 years, then you are adding 1.6 years to his life. And so average 1.4, 1.3 years life expectancy increases with this molecule. No molecule in heart failure has demonstrated this much of significant benefit, and that too in a largest trial. 8,000 patients, no heart failure trials have included. One more molecule is called as ivabradine. Ivabradine is causing bradycardia. The mechanism is IF current blockade, and the action potential goes on changing. Ivabradine will be the next lanoxin type of molecule. Up till now we were introducing bradycardia in heart failure by beta blocker, some patients getting lanoxin, but now a routine prescription ivabradine is a new heart failure therapy. So ivabradine has also come in heart failure therapy, but important thing is your patient's resting heart rate should be greater than 70 beats per minute. If more than 70 beats per minute, you introduce ivabradine and gradually increase the dose of ivabradine. Then a very important aspect here I will draw your attention is vaccines. By vaccine I mean to say that you have to go for influenza and pneumococcal vaccines. Why? Recurrent respiratory tract infection is the commonest mode of repeat hospitalization, and in an environment where we have pollution related respiratory disorders, there the best thing is to go for treatment of preventive treatment of pneumococcal infection and influenza. This is how the heart failure new therapies are going on. Thank you very much.
Thank you very much, sir, for such an informative talk on updates on heart failure and regarding the vaccination.